second of 3 workshops. And the session today will focus on mathematical modeling of infectious diseases and how they support, how that modeling can support health economic analyses. It's my great pleasure today to welcome Dr. Jim Kahn, who is visiting us from UCSF. He has come in person, so we really look forward to the day when that can happen again, but he's an emeritus professor of health policy at UCSF, and he's based at the Philip R. Lee Institute for Health Policy Studies, and he has a joint appointments in epidemiology and global health. Jim has conducted cost-effectiveness analyses for 30 years in low and middle income countries in the US on HIV treatment and prevention, and on a wide range of clinical and other topics. He hosts the Daly Show on YouTube, and I encourage you to check that out. He also researches the economics of a single payer system for health in the US, so that's great to see. So Jim, thank you so much and welcome today. It's wonderful to have you. I'm just going to go over the agenda for today. Welcome, Jim. Welcome, everybody. And Carol and Cara are also going to also here representing HEIST today. I will, after Jim's introductory session on decision trees and cost effectiveness analysis, I will give an overview of transmission models used in cost effectiveness analysis and guidance on when to use which models. And my name is Ruanne Barnabas, and I'm an associate professor in global health and allergy and infectious diseases. And I teach Epi 554, a math modeling course. And then Cara, who's a programmer in our group and has just been accepted to multiple PhD programs. She will talk a little bit about our work on modeling HIV for differentiated services for HIV. And then we'll close by 11. I really encourage, we want to know who you are and how we can help you. So I encourage you to ask questions. When you ask questions, please introduce yourself and tell us why you came to this workshop. And I hope that we will have time to answer some of those questions. But my main message for you is that HEIST is a resource. Please reach out to Carol Levin by email if you have any questions, and she will be sure that your questions gets answered. Carol, why don't you go ahead and introduce yourself and add to that?
Yes. Can you hear me okay?
Yes.
Great. Good morning, everyone. Thank you for joining. I'm one of the co-chairs of the HEIST program. And as Ruanne said, we offer a series of workshops. This is the second of third. We hope you'll join us on April 18th for one on pulling costs and modeling of effectiveness together in sort of presenting both costs and effectiveness in April. And I am a clinical associate professor in the Department of Global Health. I'm a health economist by training. So looking forward to engaging with all of you. Thank you.
Great. And Jim, we'll hand over to you. You should be able to share your screen and the slides. Thank you so much. And a very warm welcome to Seattle, where we had a beautiful sunrise just for you.
Thank you very much. Can you see my screen and hear me? Can you hear me?
Yes, we can hear you well. Your slides are not
great. And I'm going to do my presentation mode here.
Great.
Sorry to have missed the Seattle sunrise. It sounds like it was lovely. We've been having some good sunsets here in the Bay Area. Our house faces west, so we are treated to that, but we can't share it very well with our out-of-town friends these days. So we'll hope to remedy that problem soon. Once we return to actual in-person interactions. I am going to give a talk about the role of economics in assessing biomedical interventions, and in particular, it's a quick tour of one type of analysis, cost effectiveness analysis. This is a slide deck that I have put together iteratively with my colleague Elliot Marseille, who is at Health Strategies International, and my consulting identity is Supermodels for Global Health, even though I'm based primarily at UCSF. When we think about quantitative methods relevant to making decisions in clinical and population health, we need to start with some of the standard techniques of clinical epidemiology. Description about how common are diseases and risk factors, what are the causal relationships, how much can we attribute of disease Y to a particular exposure X, what mediates this, et cetera. And we can get a very thorough and far-reaching quantitative description, but that doesn't quite get us to making decisions. So there are two specific areas of quantitative methods that extend the description into the decision analysis piece. The first is, in fact, decision analysis. What are the consequences? Hold on one second. I will be right back. So decision analysis, what are the consequences, both primary and secondary, short and long term, of alternate health-related actions, different treatments, different tests, et cetera, et cetera. And secondly, if you add costs to that, you get to cost effectiveness analysis. What are the projected improvements in health with increased spending on health interventions, tests, treatments, et cetera? What is the net added cost per unit of health gain? You're going to hear me riff on that final formulation in various different ways. The net added cost per unit health gain. Another way to think about this is we do a lot of research, basic research, biology, chemistry, physiology, et cetera. We layer onto that epidemiology and biostatistics, and that helps us then make decisions about clinical practice and community health interventions. But in order to optimally inform those decisions and to think about how the relationship between what we invest and what we get, we need something like cost effectiveness analysis. So that's the broad context. Another really important thing to think about is some fundamental principles in economics. And the one I want to talk about is opportunity costs. The use of resources for one purpose precludes their use for another. So if you spend $100 on gasoline for your car, that's $100 you can't spend on some other purpose. In opportunity costs, we're really ultimately concerned about real resources like people's time and gasoline and so on. But we use a metric, we quantify all of this in a common metric called dollars. So we think about dollars or other units of currency. We think about dollars spent on one purpose, which again cannot be spent on another purpose. Seems like an obvious concept, but it has value to think in terms of opportunity costs because it counteracts a tendency we might otherwise have to unthinkingly continue this year what worked last year. So we might have a disease testing program, which was really very important last year when we didn't know how common a disease was. But maybe this year we have a much better idea and we might want to shift those resources from testing into prevention or treatment. And so it forces us to engage with those kinds of questions and thus allows us to be creative about the best use of resources given current needs and alternative actions. Resources are always limited. When we think about our work in low and middle income countries, the limits are starkly obvious and painful to think how little we spend on health in some countries. But even in a country like the United States, where resources are very large comparatively, we still need to think about the fact that resources are ultimately limited. We can't spend the entire economy on health. Currently, we spend about 18%, and that represents a limit. Of course, there are limits at various different parts of the system as well. So resource limitation is a reality. Therefore, resource allocation, how do we spend the existing money, is a consideration. Now that's the theoretical view. In practice, what we find is that decisions are not made using a formal framework. I'm going to run through these. If in the old days, when I would have people in the audience, I would ask them to raise hands with each of these, and we can't do that. But let me assure you that the experience of everyone I've talked to is that decisions are made in funny ways. For example, all cerebral aneurysms should be surgically clipped. That's the dogmatism. At UCSF, we clip all aneurysms. That's the policy approach. Or experience. I've referred a number of aneurysm patients for surgical clipping, and they've all done well. Whim, let's clip this one. Nihilism, well, it really doesn't matter. And defer to experts. The vascular surgeons tell me that we should clip. And also common, we defer to patients. So not really sure, so let's ask the patient, would you rather have surgery or live with your aneurysm untreated? Now, but I'm not opposed at all to assessing patient preferences. That's really, really important, but sometimes we can defer too much to patients without giving them the right information. So the antidote for these kinds of decisions is to find a bigger role for decision analysis, including cost effectiveness analysis. Important to remember about CEA, it does not decide goals. It is value neutral. It doesn't tell us what we're aiming for. It helps us get to where we're aiming for. Usually in health, what we're looking for is minimizing deaths, maximizing years of life, minimizing morbidity, and a metric which I'll talk about in a little bit is maximizing quality adjusted life years, which puts that all together. If that's your goal, then CEA can help to reach that goal, again, with available resources. In other words, it helps us decide what's the most efficient way to get to the goal that we've decided on. It measures the trade-off between cost and effectiveness. We are willing to pay more often, but what do we get for that? What do we get in terms of achieving our goal, which is, again, usually in our field, clinical gains? Cost effectiveness analysis needs to select among more than one course of action. One of those courses of action can be status quo or no intervention, but it's always a comparison. Intervention A versus no intervention, intervention B versus A, intervention B versus A versus no intervention. Examples include in HIV prevention, should we do an intervention like needle exchange or not? Should we do needle exchange or should we do medication-assisted treatment of drug use? Should we do both compared to nothing? Should we do universal versus targeted intervention? So let's say we're trying to reduce risk of needle sharing. Should we find a way to target our effort to those at highest risk of needle sharing, or should we do it for everyone? Should we do group counseling or individual counseling? These are, as you know, these are just a few examples of a near infinity of possible comparisons. When we think about comparing or trading off cost and effectiveness, it's useful to look at a 2x2 grid. In this grid, the rows are lower effectiveness and higher effectiveness. The columns are lower and higher cost. So two interventions have this relationship, or it could be an intervention versus the status quo. In the upper left, the red square with an A, an intervention has a lower cost and a lower effectiveness than the comparison. In that case, you would definitely, you would have a trade-off. It's not as good, but it costs less. The complement to that is the lower right-hand cell, the red cell labeled D, a higher cost and higher effectiveness. You pay more, but you get more. So those are kind of interesting. C and B a little bit less so. C is lower cost and higher effectiveness. Well, that's terrific. Let's look at the next one. Lower left, where it says dominant, it has a big plus sign. That's lower cost and higher effectiveness. An intervention costs less and does more. That's like the old beer commercial. Tastes great, less filling. It's a winner. you want to go with that. It's called dominant. The upper right, higher cost and lower effectiveness, that means it's dominated. It costs more and it's worse. So you wouldn't do that. For cost effectiveness analysis, the trade-off is when we're in the red cells, when you have lower effectiveness and lower cost, or higher cost and higher effectiveness. Now, the sticking point here is you generally don't know where your intervention is or where your comparison is, whether it's in one of these dominated or dominant cells, until you've done the analysis. So usually the decision about whether you have a trade-off comes as a result of the analysis. But when you have that trade-off, it's in those starred cells, that are the red starred cells. So how do we structure a CEA? We have three major elements. This is one way to think about it. We have inputs, outcomes of the model, and an analytic approach. So the three broad inputs into CEA are the costs of the intervention, the health effects of the disease and of the intervention, and the costs of healthcare. These are the things you need to know. What does it cost to intervene? What are the health effects of disease, and how did the intervention affect that? And what are the costs of healthcare? The cost of the intervention is usually divided into categories like this, using standard accounting methods. Personnel is often the most important category of inputs. Includes doctors, nurses, counselors, lab techs, driver's guards, and so on. Supplies are often very important. You're going to be talking about HIV interventions today. Obviously, the antiretroviral drugs, the ARVs, are a critical element in the cost of treatment of HIV. You can have services, capital goods like a lab machine, training, and physical space requirements as well. The health effects that you need to consider as inputs to the model are, first of all, the consequences of the disease portrayed. So if you're modeling HIV, what are the consequences in terms of mortality and morbidity? And particularly, what are the consequences in the absence of the intervention you're considering, say in the absence of antiretroviral therapy? What are the intended effects of the interventions, and how well do they work? So antiretrovirals improve immune functioning, reduce mortality, extend life, improve quality of life. Those are all critical to understand if you're going to do an analysis of cost effectiveness. And also, what are the side effects? Can there be serious adverse events, including long-term consequences, or even relatively minor short-term ones may be important as well. And we need to understand the cost of healthcare. Now, this is important both because we want to understand the costs associated with the disease, and we want to understand the costs averted by preventing disease, and finally, the cost of treating side effects. And these are usually quantified using both the number and cost of different types of health services. So the number of outpatient visits and what do they cost? The number of hospitalizations, usually measured in days of inpatient care. The number of different types of diagnostic tests and therapeutic procedures, and of course, drugs. So these are all of the pieces that go in. And what are the outcomes that we then get? These models will tell you, potentially tell you intermediate effects, like for HIV, the change in CD4 count or the change in the rate of decline in CD4 count. Clinical outcomes are the most important output or outcome of a model. Every model has some measure of the change in morbidity and the change in mortality associated with doing an intervention. But we don't stop there, because we're eager to be able to compare diseases to each other and intervention effects to other intervention effects. We come up with a common metric. And there are two flavors of the common metric. One is quality adjusted life years, which is, I'm going to talk more about both of these in a moment, but quality adjusted life years used most often in the US, and disability adjusted life years used more globally. These are inclusive standard metrics that include morbidity and mortality. Again, another couple of words on those in a moment. We then want to get to net costs, the intervention cost adjusted for offsetting savings or added induced costs. So what does that mean? Well, if you're preventing HIV, your intervention may cost $1 million, but the HIV cases you avert perhaps would have cost $500,000. So your net cost is $500,000, not $1 million. And sometimes you can actually save more than you spend, and that's where you get into an intervention that has a net savings overall and is therefore dominant. You can also have induced costs. If you have a testing program, for example, you're testing for HIV, you're going to be then adding the cost of treating people who have HIV. All of this needs to be calculated to arrive at net cost. And then we arrive at the incremental cost effectiveness ratio, the ICER. And I'll come back to that in a moment, but that's the measure that puts the cost effectiveness calculation together in a final in a final result. A little bit more on QALYs and DALYs. You guys are located right there with IHME. Perhaps some of you attending today are from IHME. So the IHME is, of course, a global leader in measuring the burden of disease and using DALYs, disability adjusted life years. DALYs are a measure of disease burden, lost years of life, and compromised health. You want fewer DALYs, and the health status in a DALY is measured with a disability weight. Now, and it's widely used all over the world, huge contribution from IHME. However, the way that the disability is measured has shifted over time, and it's now measured, the disability weight is measured as a preference between two health states. So it's not exactly disability, it's more like a preference weight, which makes it actually quite similar to quality adjusted life years, except for the sign. So QALYs are a measure of health, longevity and health status. Since they're a measure of health, you want more of them. You want more QALYs. And health status is measured in health state utility. 1 is perfect health and 0 is death. So it turns out that QALYs and DALYs are essentially the same magnitude, but the opposite direction. This is very useful. It turns out that sometimes the available data on disability weights from IHME and from WHO are a relatively limited set of disease states, since there are so many disease states. The data available on health state utility is actually larger. There's been research, much more research on that. And so it can be very helpful to be able to grab a health state utility and look at the disutility, the extent to which that health state utility is less than 1, and use that as the disability weight. So QALYs and DALYs are together incredibly important as an outcome metric. Now I'm going to take a detour into decision trees. Decision trees are a way to organize all of these inputs and outputs and DALYs and QALYs and everything. I'm going to talk a little bit about what it looks like, when to use it, how to construct one, how to analyze it, and some software options. First of all, a decision tree is a branching structure that leads, usually it's organized with the origin to the left, and it leads from left to right from a choice for a specified population among competing courses of action. So someone comes in with diabetes and you might have to choose between different treatment options. And it maps out the probability net of possible consequences, both transient and final outcome. So it's a map from the choices that you can make through the consequences, typically clinical consequences. Each path of consequences has an associated probability and a set of outcomes. So if someone comes in with an infection and one of the options is an antibiotic, and the antibiotic works with fairly high probability, and that person is cured, then their outcome might be perfect health. If you add up all of these different paths and their probabilities, you can assign each of the possible actions an expected value. This is the weighted mean of the relevant paths in the tree, and this is what you can use to help guide decisions among the actions. Here's what a specific tree looks like. In this particular very simplified example, you have a smoker, and the decision is whether or not to do a smoking cessation program. You can do no intervention, we'll call that standard of care, and smoking cessation. The clinical course here, again, profoundly simplified, is that that person without an intervention has a 40% chance of no cardiovascular event due to smoking. And that as a result, they live to age 80, their health status is good, and their quality adjusted life years is 20, with no cost. They didn't do the intervention, and they didn't have any associated health events. But they have a 60% chance of having a cardiovascular event, either a heart attack, an MI, or a stroke. If that happens, 30% have a chance of dying. Sorry, there's a 30% chance of dying and a 70% chance of living, but with mild impairment. If they die, estimated, halfway through their life expectancy, so 10 qualies instead of 20, they've lost 10, with a cost of $50,000. If they live, they have a mild impairment, their qualies are 19, so close to perfect health in this example, but their costs are fairly high because of this long-term impairment. If you do a weighted mean of all of these paths and outcomes, you get 17.78 qualies expected with an expected cost of $72,000. What if you do the smoking cessation program? In that case, you have reduce your risk of a cardiovascular event from 60% up here to 54% here. So it's a 10% reduction. All of the other inputs are the same, but the results, of course, are now different because you have a different weighted average. And in addition, you've added the cost, the $8,000 cost of the smoking cessation program. Now, down here, you can see the expected qualies is 18 instead of 17.78, so a small gain. And the expected cost goes up as well. 0.22 gain in qualies, $800 gain in expected costs. Now we talk about the ICER, the incremental cost effectiveness ratio. This also gives me an opportunity to mention the other video that I have online called The ICER Man Cometh, which includes the Daly Show. It's about 70 minutes, and it's a brief course in cost effectiveness analysis, The ICER Man Cometh. So the ICER is the cost effectiveness ratio, the difference in cost between two courses of action, divided by the difference in health outcomes. So difference in cost divided by difference in health outcomes. Slightly more precisely, it is the net cost with the intervention minus the net cost with no intervention. Remember, net cost is the cost of the intervention itself plus any change in downstream healthcare costs. And all of that's divided by the qualies expected with the intervention minus the qualies with no intervention. So delta net cost over delta qualies. And when you put numbers to that, from the example that we had, $800 divided by 0.22, you find $3,600 per quality gained. In the United States, that is widely considered to be a very attractive cost effectiveness ratio, where we routinely are willing to spend things that cost more like $50,000 or $100,000 or more per quality gain. So that's a very good deal in the US. When should you use a decision tree? In my view, when you're conceptualizing a problem, almost always. In order to really understand the relationship between the choices being made and the likely outcomes, it's extremely useful to use a decision tree structure to portray the link between what you do and what you expect as outcomes. I've done many, many cost effectiveness analyses, and when I talk with experts in the relevant clinical areas and we build a tree and look at it together, we always realize that there are considerations that they may have overlooked or I may have misunderstood. So it's an incredibly important way to understand the potential paths and the causal links and all of that. Operationalizing, I like to use decision trees to translate the conceptual tree into an operating model. I use Excel a lot, as you just saw. I have used, and many of my collaborators have used TreeAge, which also uses a tree structure. You don't need to do it that way. The math doesn't require a tree. It's just a preference, but it can be extremely helpful to build a tree to echo the conceptualization. And then there may be additional calculations. For example, epidemic spread is not something that you necessarily want to do with a tree, but then you can link the tree to other calculation structures. And finally, in presentations, such as in an article, it's often quite useful to present the tree, or more likely a very simple excerpt from the tree that shows the general structure, and then the full tree can go in an appendix or supplemental materials. But many readers will find it easier to understand the problem if they see a tree. In order to construct a tree, you need to know the population. So, for example, someone who comes in with known diabetes and you're considering treatment options, could be someone who has a fever and you're trying to assess what's causing it. You start with that decision node, a square, which says, what are the various options that are being considered. And in order to be a good analysis, you need to consider all of the plausible or relevant action options. If there are 5 possible things that a normal practitioner would think about, and you only include 2, that's incomplete and misleading. Decision trees require that later decisions, like if such and such happens, then I'll modify the treatment protocol. It requires that all of that be brought to the decision node. That's a longer discussion. There are technical reasons for that, but all of the decisions need to be up front. And then you have the chance nodes, which are circles. And in each such node, the probabilities have to sum up to 100%. All of the options of things that can happen have to be represented. So, for example, if you have a surgery where you have some risk of infection as well as some risk of slicing a blood vessel by mistake because it's close surgery, you need to represent those separately. So they need to all be there, but they need to be mutually exclusive. So sometimes these chance nodes can get a little complicated. Usually the chance nodes are reduced to a series of dichotomous choices. They're much easier to manipulate. So most chance nodes have just 2 arms. You then have terminal node utilities. That means the outcomes, so the health and cost outcomes. Then you can calculate the expected values, again, weighted means. And really important, in an RCT, you establish the analytic structure in advance. That's best science. You don't want to be changing how you're analyzing things after the fact. You want to have do the research, collect the data, finalize and close the data set, and then do analyses that you've agreed on ahead of time. That's best practice. It's really different for a decision tree and for cost effectiveness analysis. You build a tree, you start to work with it, you realize that you omitted an issue and you need to add it. So you go back and you modify the tree. You then find some really interesting findings and you realize that if you added another branch, you could further explore those findings. And so there's definitely an iterative cycle, and the trick that comes more and more with experience is to know when you've done enough, when to stop refining and just say that you've captured all the key issues and it's time to proceed. In any case, of course, reviewers may ask for other kinds of analyses, but this iteration is part of the life of doing these kinds of analyses. Here's how you analyze a decision tree. In this particular example, there were 4 options. Here they are. Here are the results. Notice they are ordered from least to most expensive. So option C in our original choice turns out to be the second most expensive, so it's second in this list. Start with the cost, then the difference in costs, then the DALYs, and remember DALYs are bad, you want to avert them. So the DALYs go down, if you're lucky, and then delta DALYs. And here you can see that going from option A to C results in 2 DALYs averted. But then going from C to B, even though the cost goes up, there are DALYs gained, which is a bad thing. So as a result, option B, as compared with option C, is dominated. It's more expensive and less effective. So you wouldn't be very interested in that. And when you then get to option D, sorry for the phone ringing. Let's see if I can stop that. Oh, my wife got it. When you get to option D, you are going to compare it not to option B, which was dominated, but you're going to compare it to option C. So that's the general structure. Oops, keep going backwards. That's the general structure. You will also do sensitivity analysis. I'll come back to that in a moment. Software choices. Excel is an old mainstay. It's familiar. It's generic. People know it. It's flexible. You can easily incorporate a lot of different kinds of calculations. There are standard software packages for doing extensive sensitivity analyses like Crystal Ball and At Risk, and then there's another one I'm blanking. I'll think of it in a second. Another add-on that can do the same. I like Excel. I use it. I'm a little bit old-fashioned. More and more people are now switching to Triage. Triage, when it came out, was clever but clunky. The manual was inaccurate and incomplete, but over time it has become much slicker. The manual's better. Everything's much better about it. So if you're starting out and you have any kind of tolerance for learning new software, then I definitely recommend that you look into Triage. And for various aspects of decision and cost effectiveness analysis, it can be extremely efficient. And then At Risk is a newer program that has some special features, and I'm so sorry, I'm blanking on, come up to me. There are other programs as well, but these are the main ones that you have a choice between. And let me talk for a minute about the why the I in ICER is so important. The I is incremental. So what this means is you need to look at the various options that are available in order and not compare each option to the reference case. Like in this case, no treatment. Then drug A is a generic drug treatment. Drug B is a brand name, and drug C is a biological. So in this assessment, going from no drug to A adds $1,000, but it reduces care costs and you gain quality. So because it reduces overall costs, drug A costs less, gains qualities, it is dominant over no treatment. By comparison, drug B, $10,000, does bring some more health benefits. Here we can see it adds $7,000 to cost overall. It adds half a quality. So that's $14,000 compared with drug A. And then drug C, which is the biologic, costs an additional $63,000, very expensive, adds another half a quality. So compared to drug B, which is the brand name, the biologic costs $126,000 per quality gain. So that's quite a jump up, and in fact might be beyond what insurers are willing to pay, $126,000 per quality. Even in the US, that's quite expensive. If you did a non-incremental comparison, that if you compared each drug to no treatment, you would be misled. So the first result's the same, because we were already comparing drug A to no treatment. But if you compare drug B to no treatment directly, then the ICER, or the cost effectiveness ratio, is 2,000 instead of 14. So they're both cost effective, but they're pretty different. But if you do the same thing for drug C, the biologic, then the cost effectiveness ratio is 23,000, which is quite attractive, but it's misleading because you're ignoring the fact that you have the option to do drug A and drug B. So these direct comparisons to the no treatment option are misleading and bad practice and shouldn't be done. There are two examples I like to talk about. One I'll just mention, that's example 2, adult male circumcision in South Africa. We compared doing adult male circumcision to not doing it. And we found that it cost $181 per HIV infection averted in this part of South Africa without adjusting for HIV care. When we adjusted for HIV care, so in other words, allowed for the averted cost of HIV infections that didn't happen, the cost was $2.4 million saved for each 1,000 adult male circumcisions. So the intervention was dominant. It was cheaper and better. And of course, in that circumstance, there's no need to calculate a cost effectiveness ratio because there's no trade-off. It's just cheaper and better. The other one is new antivirals for HCV. Most of you probably realize that a few years ago, there was a revolution in the treatment of HCV. A whole set of new highly effective antivirals came out with relatively short treatment courses, but very expensive. So we looked at this, and here we go. This is the main table from that paper. We looked in particular at sofosbuvir and ledipasvir, if I'm saying that right. First of all, we looked at treating everyone versus treating those only with late stage liver fibrosis. So treating everyone as soon as we know they're infected versus treating only once the liver has problems. And what we found over here, I'm going to skip over a lot of the details, but what we found is that the ICER was $39,000 per quality gain. So it looks like a good deal to treat everyone. But then we said, let's be more precise about this. Let's not just do treat all versus treat late. Let's do it stage by stage. So we said our reference case is just not treating. Then the next option is treating only very late in disease, waiting until late in disease. Then a little bit earlier, and then treat everyone. So we compared these incrementally. And what we found is that the incremental cost effectiveness ratio was, so stage 4 versus no treatment was clearly appealing, $11,000 per quality gain. Stage 3, $6,500. Stage 2, so you're starting now to get to pretty early disease, $20,000 per quality gain. Stage 1, that is early fibrosis, $81,000 per quality gain. By most standards, a good deal. But treating everyone versus treating just people with some evidence of liver fibrosis, not so attractive, $187,000 per quality gain. So, and that's because many people who don't have fibrosis will, even though they have HCV, will never get sick. And so you're basically treating a whole lot of people who will never get sick. And that's why it's not very cost effective. Analytic approach. In doing a cost effectiveness analysis, you need to think about some of these issues. How many years are you modeling? Oftentimes, it's easier to know what's going to happen in the near term, but there are consequences down the line, potentially 5, 10, and 20 years down the line. So there's a trade-off between accuracy and relevance. What I usually do is model both, but present the results for the shorter term, and then say, if we project down the line, it will look like this. And this relates to the second issue, which is empirical data versus model. A lot of times, if you're doing your analysis as part of or in conjunction with the clinical trial, you will have empirical data for the first 2 to 3 years, the length of follow-up during the study. And after that, you're going to have to make some projections, or you're going to have to do some modeling. And so this relates to time frame. And again, what I usually do is I say, here are the results with empirically measured clinical outcomes, and here are the results if we make the following assumptions about what will happen over time. Also important to look at the economic perspective. All analyses by recommendation of the people who make these recommendations, the panels on best practice, is that all analysis should include a societal perspective, but sometimes you may want to include other perspectives as well. And of course, in many low-income countries, the societal perspective and the medical system perspective are often very similar or the same. Here's an example of why you might want to think about who's paying. If you look at the top left, where an intervention is cost effective from society's perspective and also from the perspective of the payer, which might be the government or an insurer, then everything's aligned and it's a no-brainer. You'd want to do this intervention. What if an intervention is cost effective from societal perspective, but not from the point of view of a payer, say not the insurer? Here you go. You might want to offer a subsidy. It may be in the interest of society to subsidize this service in order to obtain this cost-effective outcome, because otherwise this payer may not want to invest in something that's not cost-effective. I'll leave it at that. Those are the two most common circumstances that we think about. And then we get now finally to uncertainties. A base case analysis, or also called a best estimate, does incorporate the best estimates for input values. But these analyses will typically have 25 to 50 or more inputs. And oftentimes there's uncertainty. There are different kinds of uncertainty. One is pure statistical uncertainty, that 95% confidence interval. You have a fabulous study that's directly relevant to what you're trying to do. But of course, there's a 95% confidence interval around the efficacy estimate. Another kind of uncertainty is that you have a good data point, but it is not perfectly aligned with your situation. Perhaps you have a study from Canada, and whereas you're looking at something in the United States, or you have a study that's 10 years old and clinical practice has changed a little bit in the interim. So you have some uncertainty about the generalizability from the study you found and to the value to use for your analysis. And there are other kinds of uncertainty as well. So there are going to be, each input's going to have some range of uncertainty. And we use sensitivity analyses to explore how the results of the analysis change with uncertainty in input values. So the simplest and most common type of sensitivity analysis is one way. Take each value by itself, so that efficacy number or the cost of a treatment or whatever it is, and vary it for what you think is a reasonable range, whether it's based on the statistical uncertainty or some other consideration. My recommendation is to err on the high side of the range. There's nothing reviewers like less than an evident, unfairly narrow uncertainty bound. Everyone wants to see the uncertainty analysis, so the broadest reasonable uncertainty bounds. And that's summarized in something called a tornado diagram, which I'll show you in a minute. Then there are two ways, so maybe drug price and efficacy varied together. Scenarios, what's the best and worst case for cost effectiveness? In particular, best case scenarios are extremely useful if you're trying to demonstrate that under no plausible circumstances can an intervention be cost effective. If you show that for very favorable assumptions for the 4 key inputs to the analysis, this intervention still looks unattractive economically, that's a very powerful statement. And finally, multivariate or probabilistic sensitivity analysis, sometimes called Monte Carlo or Latin hypercube. All of the variables are varied at once, reflecting their probability distributions, and occasionally, if you're lucky, the dependencies among the variables. So here's a tornado diagram. It looks a little bit like a tornado on the right there. This is from our analysis of HCV drugs. And what we found was the most important input to our analysis was the age of the cohorts that had HCV. And it turns out that older cohorts, so 70-year-olds who don't have a huge life ahead of them, still maybe 20, 30 years, may die of other things before the HCV becomes clinically important. They had the worst cost effectiveness ratio, and the younger cohorts, conversely, had the most favorable cost effectiveness ratios. The cost of the drugs, very important. And of course, there's a huge uncertainty for these drugs. They were highly expensive, but already when we were doing the analysis, there were extensive negotiations ongoing regarding the price of the drug. And you can see we have a long list of inputs. And after this one, they don't make a huge difference in the cost effectiveness ratio. And so this is very useful to help you focus in on the most important factors. This is an example of a multivariate sensitivity analysis applied to 7 different interventions. This is a project looking at the indirect effects of COVID, things like the risks of increased opioid use, increased alcohol, homelessness, and the interventions to address them. The vertical axis is QALYs gained. This is per million population. So what we said is a million population, apply the intervention to the people who are affected, 20% of them. QALYs gained, ranging up to 50,000, and then overall net savings. All of these interventions, the way we did the analysis, including non-medical direct costs and long-term effects and so on, all of them looked like they had net savings, and so this is overall net savings. And what you can see is each set of dots, which represents 5,000 iterations of each analysis, represents the distribution of possible results. For example, this orange one is a nurse family home visiting for interpersonal violence. And what we found that our point estimate was right about here, but you can see that the QALYs gained varied from about 2 to about 40,000, and the net savings varied from about 400 million in this population of 1 million to a small net costs over here. And the other ones are all in the net savings side for the most part. This is a really good way to capture the overall variation. Finally, most of you will never do a cost effectiveness analysis. Well, I don't know, maybe people attending a HEIST seminar, that's not true. But some of you probably won't do a cost effectiveness analysis. And so there are some hints here on how to read the literature, because you definitely will read the literature about cost effectiveness. First of all, is the comparison that's being considered reasonable? Are the options appropriate? Are they all there? Are there any there that shouldn't be there? So are the options appropriate? Whose costs and benefits are being considered? Again, it's a societal perspective is recommended, but other perspectives are welcome too. Is the analytic approach well laid out, explicit, and reasonable? Are the data inputs appropriate? Certainly there are examples of people who have not done a due diligence on their searching and have omitted important studies. And that can lead to significant changes in the results and also raise questions of bias. The comparison increments approach appropriate? As I mentioned, when there is an intermediate option, like when there is a drug B, you can't compare drug C to drug A if B is a reasonable intermediate option. And there are mistakes in published papers along these lines. Not very common, but definitely happens. And then are the uncertainties fully explored with the sensitivity analysis? Whoops, didn't mean to do that. This is super important to let you know how the model is working and to let you know how these uncertainties affect the results, and they influence your confidence in the findings. And that's where I'll stop. Of course, hoping that I can take some questions.
Wonderful, Jim. Thank you so much. We have a question in the chat. Carol asked, oh yeah, go ahead, Carol, sorry.
Yeah,
We'll open to other
I
questions.
thought it might be useful just for our participants, Jim, when you gave the example of, you just presented adjusted for HIV care which means you included the future costs averted or unadjusted. I'm just wondering if that's how you presented it in the paper, or isn't it, or were you just making a point for these slides? Because, yeah, so that's my question.
Yeah, we struggled with that a little bit. We wanted to keep it simple and accessible. So we did focus on the result without adjusting for the lifetime costs. We just wanted to say it costs $181 to avert an infection. And by the way, that's a heck of a lot less than the cost of treating an infection. Therefore, the intervention saves the money and is dominant. But yeah, we made that decision to give them that simple, we thought, fairly compelling result.
Super. Jim will be leaving after this session, so please do ask questions. Tessa, I see you have your hand up, and either unmute and speak or use the raise hand function. Anything is fine. Go ahead, or put it in the chat. Tessa, go ahead with your question. Thanks.
Hi, I'm Tessa. I'm a research coordinator in the Global Mental Health Program, and I am starting a PhD at UW this fall, and I'm very interested in cost effectiveness and health economics research. I was wondering, so in kind of early on, you talked about the dominant and dominated, and you mentioned this later on in limitations of cost effectiveness analyses, but it seems like timing and time in general of benefit is a huge factor when we consider this. For example, like in pediatric surgery, very, very expensive pediatric surgeries could have huge life-saving benefits in terms of years of life lived, especially for neonatal surgeries. And so how do you think about some of these like astronomical costs that also have incredibly high benefits for DALYs or reduced DALYs, but might be seen much later on and sort of like the normal life for a long time versus a huge cost right up front, and how that might be?
Yeah, so there are at least two issues here, and one is if you avert a death in the near term, how do you capture the full life of the full duration of life? And there's a standard method to capture the value of a life saved. And what you do is you take all of the future expected years of life and you discount them to the present, and it comes out to if for a young person, it comes out to about 30 discounted life years or discounted DALYs averted. And so that in that sense, it's very easy and extremely standard to capture the downstream life benefits. Now, the trickier issue is, what if someone has a better quality of life or a reduced risk of death? It's not that they're going to survive for their whole life, but their risk of death goes down, and it goes down for 3 years, but you think maybe their risk of death will stay low for another 20 years, but you don't have empirical evidence. And then you need to make some explicit assumptions about what will happen in the future. And as long as you lay that out explicitly in the analysis and do sensitivity analyses on it, then your reviewers will be grateful and your readers will be grateful that you have attempted to understand the downstream consequences.
And a follow-up question to that is, when you look at sort of the time of life that a lot of these interventions happen, is the contributing to like number of work days and sort of value back to economy built into the cost of these interventions, like ability to work and
yeah,
economically?
So that's a little bit of a tricky issue. Both QALYs and DALYs, according to many people, including me, implicitly include the rating of the quality of life, the disability weight and the health state utility implicitly include the ability to have a productive work life. And so normally the value of gained productivity is not quantified in a cost effectiveness analysis. That has long been the recommendation of the panel on cost effectiveness analysis in health in the US. The more recent panel, the second panel, modified that and argued that productivity is actually not reflected in health state utility and therefore should be added on. I disagree, many of us do. And then if you do a fuller consideration like that, it also then becomes closer to something called a cost benefit analysis, which we didn't talk about today, but which is a related kind of method. Sorry, that was a bit of a complex answer. It's a bit of a complex issue.
Thank you.
We had a question from Adino. Adino, would you like to ask it? Please feel to come off mute and ask it. Go ahead. Thanks.
Sure, I kind of think so much. That was a really great presentation. My question is about some of the interventions we may design to model. Sometimes we may have some public health interventions that might not be strictly mutually exclusive. How strict should we be about this, the exclusiveness of our possible interventions, and is there any kind of approach we should follow when we have interventions that are not mutually exclusive?
So I really apologize. My sound quality is not great and I could not understand. Did someone understand Adino's question?
Sure. He also put it in the chat, so I'll just read it. Sometimes we may need to compare public health interventions that might not be strictly mutually exclusive. Any specific recommendations in this kind of situation? So this might be the...
When the interventions are not mutually exclusive.
Yep.
Well, it depends on the specific circumstance. I need to look at the specific circumstances. Sometimes you can deal with that. If you're talking about not being mutually exclusive in the implementation strategy, there may be some efficiencies. Maybe they share the, for example, we did an analysis years ago in Kenya of an integrated health campaign that had interventions for HIV, TB, and malaria. And because they were together, they had some shared costs, which was an efficiency. So we were able to capture that efficiency. If that's the kind of interaction you're talking about, then you look for implementation efficiencies. If there are biological interactions, that's another question. And sometimes that can get pretty tricky. Depends how well you understand the interaction of two diseases. So if you have a specific example or two, Adino, that you want to send me, and anyone is welcome to email me afterwards with specific questions. I'd be happy to take a shot at it later.
Thanks so much. Thank you.
Jim, thank you so much. We're always so grateful for your presentations because they really capture conceptually what we are trying to achieve in health economics and in assessing cost effectiveness. One of the things I love about Jim's presentations is he has complete confidence that we can do math, and he really tries and helps us think about how to solve complex problems. And so we're just really delighted to have you here. We know you have so many demands on your time, but we appreciate all your experience and your work in the field and look forward to continuing this collaboration within HEIST. Thanks so much.
Well, my pleasure. It's great to see you again. And let's stay in touch despite this little barrier we have these days.
Yes, absolutely.
Thank you,
Bye,
Jim.
folks.
Bye-bye.
Okay.
Your sushi's in the fridge.
Okay, so
Okay, there's one for Mom.
we're going to switch tacks now. So Jim did a really great job
Eating your sushi now?
about discussing,
Okay. Yes, you can.
sorry, did a really great job of discussing decision tree models and cost effectiveness and how we use modeling and costs in order to estimate cost effectiveness. And I'm going to change directions now and talk about math models for health economic analyses. And I'm really going to focus on infectious disease modeling. Please feel free to interrupt me in the chat or by raising your hand or just by directly I'm just going to open the chat here so I have it open, or just by unmuting and speaking, especially if you have a point of clarification so you can continue to follow the slides. And I will talk for about 25 minutes, 25 to 30 minutes, and then hand over to Cara, who's going to give a great example. But I really want to start with a summary of where we are regarding math modeling, and then I'll come back to the summary at the end, but I'll go through the talk and extrapolate on each of these points. We want to show you today that mathematical modeling can be used to estimate health outcomes. Jim talked a little bit about how we measure health outcomes, and we want to be able to get to DALYs and QALYs, and so we need to then understand the effect of interventions on health states. So for example, getting tested is not enough. We really need to know if someone is tested, do they access treatment, and is that effective, and does that change their health outcomes? So we can use models to look at this question. Infectious disease models are different from linear decision tree models, and that they help us capture indirect effects. And I'll talk about what those indirect effects are. But one example is herd immunity, which we all know about and are hoping to achieve for SARS-CoV-2. And the third point is that we can use study data to parameterize models. And ideally, all our health economic analyses would be deeply grounded and rooted in empiric data and in field studies. And that's very important. Jim talked about sharing work with clinicians, and the models must represent clinically meaningful states, but in the same way, they must really be grounded in data. And if they're not grounded in data, assumptions need to be quite clear and the rationale behind that laid out. So I'll go through a brief introduction, give some examples, and then end with discussing when to use which model. So overall, models are frameworks for understanding and communicating infectious diseases, and the assumptions are explicit, and that helps us delineate which parameters are based on evidence. Jim mentioned that he often starts with the decision tree, and that's a very useful tool to thinking about complex problems. And that's really what mathematical models do, is they help us think about complex problems. And they help us delineate what we do and don't know. And even though we put a lot of numbers into models and have many assumptions, these results can sometimes really just guide us qualitatively rather than give us exact estimates. And once we have validated models, we can use them to estimate the potential impact of interventions. And we can also use models to extrapolate beyond observed data and to link intermediate and final endpoints. So for example, HPV vaccine trials often measure incident persistent HPV as a surrogate marker for cervical cancer. And so we can use models to link intermediate and final endpoints, and then also to generalize the results to other settings and to simulate randomized control trials where those don't exist. And we can also use them to think about new research questions. So these models can be quite helpful. They take into account many things that we know about disease, so they help us synthesize knowledge. They can take into account natural history, evolution, interventions, demography, epidemiology, contact patterns. Those all can go into models. And then models can give us insight into mechanism. They can help us understand fundamental parameters. They can provide detailed predictions, and they can also can be used for control policy optimization. Not all models are mathematical, but that's what will be our focus today. We use math models when we can't use classical epidemiology to answer all questions about infectious disease dynamics. And I'll just share an example with you. Classical epidemiology really teaches us a lot about infectious diseases, but there are additional characteristics for infectious disease that are really related to transmission of a pathogen. And if we have transmission, and we're interested in transmission, then we do need dynamic models. So for example, prevalence of infection is a risk factor for incidence, and prevalence reflects incidence at an earlier time point. And that leads to nonlinear dynamics in infectious diseases. And we can think about this in classic regression that does not incorporate prevalence. And I'll just give this example of the population attributable fraction, which is useful epidemiologically, and it's the proportion of a disease in a population that is attributable to the presence of the risk factor in the population. So it might be incidence in the total population minus incidence in unexposed over incidence total times 100. And so we can think about that. And I love that Jim used the example of circumcision. So here we can see it again. The risk factor here is not being circumcised. And here's the expected incidence among 1,000 susceptible individuals, of which 500 men here are circumcised. And you can see here that the difference in the number infected. The total population is the same, but for circumcised men, there were 6 infections, and for uncircumcised men, there were 10 infections. And so then using the approach of a population attributable risk, you can estimate that 25% of infections are due to not being circumcised. But if we use a math model, we find that actually it's a little higher. 32% of infections are attributable to not being circumcised. And why is that? Well, this is really the crux of the matter, that the population attributable fraction is a linear calculation, but infectious diseases depend on nonlinear effects. For example, if you think about the concept of herd immunity, circumcision also protects uncircumcised individuals. And we really think about this a lot now with COVID-19 and SARS-CoV-2 transmission and vaccination. We know that with vaccination, more people will be protected than those who are vaccinated, because we expect to have secondary benefits of vaccination. And so this really linear epidemiological tool is not sufficient for infectious diseases. When we use mathematical models for infectious diseases, we can capture R0, which captures the nonlinear dynamics of infectious diseases. And I love that everyone now is talking about the R0 of SARS-CoV-2, and everyone knows what it is. So R0, the basic reproductive number, is the number of new infections caused by one infection in an entirely susceptible population. And that's different from, and we really were able to observe the basic reproductive number early in the epidemic for COVID-19. But the effective reproductive number, what we see today, is the number of new infections caused by one infection at a given time. And we know with our transmission mitigation strategies that we were able to bring the R0 down to just about 1 for COVID at the moment. And the R0 is a function that takes into account the likelihood of transmission, the contact rate, and the duration of infectiousness. And so I'll just show you here in this figure, in this schematic, if you have an entirely susceptible population and you introduce one infectious person, and they go on to have several contacts, and you can see here that the R0 here is 2. Each infectious individual results in 2 more infections. But if we're able to vaccinate here 75% of the population, and we introduce the same infectious individual and they have multiple contacts, transmission does occur through one case, but not again. And here the effective reproductive number is less than 1, 0.5. And so then we're able to eliminate the infection. And this is what dynamic models capture that we don't capture through classic epidemiology. So how do we incorporate these important issues into modeling? And so the answer really depends on the population to be modeled, the data availability, the scientific question, and to some extent the modeler's preferences. So I'll talk mostly today about dynamic models because Jim has done a good job of talking about linear models, which are appropriate for many questions, especially for non-infectious diseases. And you can think about the complexity increasing as you add infectious disease transmission and as you add stochasticity. So this is what you would often see in a paper for an HIV infectious disease model, where susceptible individuals acquire HIV and they either go on to treatment or are not treated. and the treatment either succeeds or fails. So you can see this building on the tree concept that, that you heard about in the first presentation. But if there's no treatment or people come off treatment, you can go on to here to develop AIDS in this HIV model. So you can think about models like maps. They're abstractions, they have scale, but we must trade off realism with with being more general. And here you can see this map of Seattle, which is, and if you could zoom in, you can see a map here of the health sciences building. And these maps give you different scales. And so this model that I presented here is at population level, but you can imagine a more detailed map giving you an individual level type of observation. We can use models at any stage of the scientific process, early on from just observational data. We can use models with clinical trial data and for implementation science. And there is an effort to freeze models and look to see how useful they really are. Okay, so I'm going to go on now to show an example of using a model to look at the outcomes of infectious diseases. And I like this forward-looking model, now more than 12 years old, 13 years old, of HIV. It was the very first model that looked at test and treat for HIV. And this was an entirely conceptual model that wanted to look at if you put everybody on ART, could you really see dramatic decreases in HIV incidence, which they predicted. And the importance of this model was it was really used as a conceptual tool, and it did spur on the field to make HIV treatment more widely available. And now we are able to see the benefits of HIV and decreases in incidence. But of course, the models need to be balanced with realism and with being able to deliver complex interventions. I'm going to just give this example from KwaZulu-Natal, where we were able to do some work delivering antiretroviral therapy after the kind of blue sky thinking of models. And we were able to show high uptake of antiretroviral therapy, but not quite as perfect as predicted in the blue sky thinking model. But we were able then to use data from the study. So we took data from the study and we were able to put participants from this randomized clinical trial into these compartments for HIV dependent on their CD4 count, on whether or not they linked to ART. So we had very realistic assumptions in this model, and thus we're able to show what the probable impact would be on population level incidence. And we were able to gather all these data from the randomized control trials to include in models. And these data from the study population used demographics, mixing patterns, natural history, transmission probability, factors that change susceptibility and infectiousness, and most importantly, the effect of the intervention. And we also had data on engagement in healthcare from the study. So we used the study data to parameterize this model, and it gave us the expected impact on HIV prevalence. And in fact, we saw really no changes in HIV prevalence over time, because as people were initiated on antiretroviral therapy, they continue to survive and be counted as prevalent infections. But we did show decreases. We predicted that there would be decreases in incidence. And the model was quite realistic and captured every 5 years, there would be a campaign of testing and linkage to care. And that's why there's this sawtooth pattern here for the incidence decreasing over time. And then we were able to estimate cost effectiveness. And Jim's already introduced you to the terms of dominated and which strategies were effective for and cost effective for linking people to care. And I just want to show you a map of a different type of model. So first we looked at population level models, and this model is a household level model. And this model shows every household here in blue. The green squares represent men, the yellow triangles represent women, the solid lines are stable sexual partnerships, and the dotted lines are temporary sexual partnerships. And then using this model at sort of a totally different level, we could capture engagement in care and viral suppression, and then show the predicted cost effectiveness of community-based testing and linkage to care. And I won't go into details about the results because the main aim here is just to show you that you can have models at different levels. You can have every individual in a household, or you could have groups of people, for example, by CD4 count, as I showed earlier. So today you heard talks on different types of models, about decision tree models and about infectious disease models. And of course, you could do an entire course on infectious disease modeling, as some of you who are attending today have done. But I just want to end with this very important slide about when to use which model. So once you have your scientific question, you need to think about, is transmission important? Even if you are working on an infectious disease, transmission might not be important. You might be really looking at, once people are diagnosed with HIV, what is the best way to avert opportunistic infections or the medical complications of advanced HIV. And in that case, you might be working on an infectious disease, but you might be able to answer your question using a linear model, and a decision tree might be really the best way of thinking about interventions to prevent opportunistic infections. But if you are interested in transmission and you are interested in the population level effects, then you might think about that transmission is important, yes. And if you are just doing a population-based model, then you don't need to model individuals, and then you can use a systems dynamic model like a compartmental model. If you do need to model in individuals, then you can use a discrete event simulation model and an individual based model similar to the household model that I showed. So you need to think about, is the interaction between patients important? And there might be levels of contact that you want to think about that are important. If you're able to use a linear model, you can think about, do you need to model recursive events, so repeated events such as repeated screenings? And if not, then you can use a decision tree model. If you do need to model recursive events and you want to represent lots of health states, then a Markov model is probably the best. But if you do, a Markov model is probably the best if you do not need to represent a lot of health states. But if you do need to represent a lot of health states, then an individual sampling model is the best. And we'll share these slides. But I want to emphasize that early on, if you're new to health economics and to modeling, it's a really good step to discuss this with an experienced modeler or health economist, because you want to be sure early on in your project that you're making decisions that are helpful for the next steps. So I'll come back here and I'll end here with the summary where I started, that modeling can be used to estimate health outcomes. Infectious disease modeling is a useful tool for capturing indirect effects, such as herd immunity. And we can use study data to parameterize models. And I want to recommend that where possible, this really close interaction with empiric data collection so that the models are most useful. It's also really fun to work directly with study teams, but it's not always required. We can learn a lot from all the evidence that's already in the literature, and especially at the start of a project, thinking about modeling and thinking about complex problems using modeling and what's available in the literature is a really useful exercise. Okay, that's my email address. I'm happy to take questions now. I also want to make sure that we have good time for Cara, who's going to show us a really nice example of a compartmental model. And this is new information and hot off the press. And this is for a study that we just completed and are working on the cost effectiveness for at the moment. So maybe I'll have Cara go and then she and I can take questions together.
Okay, thanks, Ruanne. Hopefully everyone can see slides now. Okay, great. So thank you. So my name is Cara, and I'm a research programmer working in the International Clinical Research Center with Ruanne, and primarily focused on mathematical modeling of interventions for HIV and for cervical treatment and prevention in South Africa. And I think that Jim and Ruanne have both set me up perfectly for what I'm going to talk about today. This is going to be taking a lot of these concepts that we've heard about in the first two talks and bringing that together into a case study where we look at the population impact of community-based ART in South Africa. So as Ruanne described, models have an important role in supporting these comparative program analyses. And there's this need to generate evidence on approaches for meeting global and country level targets. So here we're using the example of HIV prevention and policy programs. And so in one case, this could be the UN AIDS 95-95-95 goal or something else. And so in order to generate this evidence, we can use existing transmission models to predict the population level impact of a novel approach. And in order to do this, we can use effect measures from randomized control trials. We can then combine population level impact with an economic evaluation or cost effectiveness analysis to assess if the investment is a good use of resources. And in this presentation, I'm going to be highlighting how to model population impacts and then provide a quick preview on how you can combine this with cost data in a cost effectiveness analysis. So for the study background and objectives, in the South African province of KwaZulu-Natal, HIV prevalence is 27%. Significant efforts have been made to provide free antiretroviral therapy, or ART, to all persons living with HIV, but gaps in uptake and retention leave a lower proportion of men virally suppressed than women. Differentiated service delivery mechanisms are recommended by the World Health Organization as a way to adapt services to meet patient needs. This can be flexible locations, reduced frequency of refills, and task shifting of ART treatment delivery. However, this flexibility is typically only offered to individuals with stable viral load, or persons who have been on treatment for a period of time. The delivery optimization of antiretroviral therapy, or DUART study, this is one that Ruanne led, recently published results demonstrating that community-based ART initiation, monitoring, and refills significantly increase viral suppression compared to standard delivery of ART in the clinic. So as seen in the right, or on the right, in the purple incremental bars, the increase in viral suppression with community-based ART was particularly notable among men, such that the gender disparity was eliminated. And a strength of this study is that it excluded patients with stable viral load, therefore allowing a true comparison of the outcomes in persons new to treatment with a detectable viral load with either of the clinic or community-based interventions. So given this evidence that community-based ART benefits the individual, we aim to predict the population level impact of implementing community-based ART in KwaZulu-Natal, one of the DUART study sites. So in this way, we were able to take the DUART randomized control trial and use this, and as well as population surveys, to parameterize an existing dynamic deterministic compartmental model. And so that was one of those top blocks in the diagram that Ruanne just showed, because we wanted to be able to capture HIV transmission and have that dynamic component. Our model tracks heterosexual HIV transmission, disease progression through either CD4 plus T cell count or viral load, as well as treatment with ART, and is stratified by both gender and age. Based on those viral suppression outcomes from DUART and estimates of HIV testing coverage, we estimate that with clinic-based services, 62% of women and 40% of men living with HIV are diagnosed on ART and virally suppressed. This baseline clinic-based ART scenario is shown by the gray bars on the right. And we anticipate that community-based ART will be used as an additional intervention to engage with persons not already in care. We therefore model a scenario with additional HIV testing campaigns conducted every 5 years that connect persons not reached in the clinic to community-based ART, therefore raising the percent diagnosed on ART and virally suppressed to about 67%, shown by these gold bars. In our modeling, program implementation begins in 2020, and we evaluate both the 5 and 40-year impacts of clinic or community-based ART on HIV incidence, mortality, and prevalence. Under the current clinic-based services, HIV incidence in 2020 is approximately 2.7% among women and about half or 1.2% among men. By contrast, HIV mortality rates are similar by gender, reflecting that although a higher proportion of women are living with HIV, men are less likely to be virally suppressed. This figure on the right shows the percent reduction in HIV outcomes since 2020 with community-based ART. Reduction in HIV incidence is shown for each gender in black, and reduction in HIV mortality is shown in the gray lines. The shaded region represents the range of estimates using the 25 best fitting model parameter sets. So we spoke before about using things like tornado diagrams or different kinds of plots to represent uncertainty or sensitivity in your cost effectiveness analysis, but this is a way to capture uncertainty in the actual model predictions. So within 5 years, we estimate that community-based ART delivery will reduce HIV incidence in women by 35%, and reduce HIV mortality among men by 40%. And by 2060, you see the opposite trend by gender, with HIV mortality among women decreased by 38% compared to those 2020 rates, and HIV incidence among men decreasing by 35% compared to 2020 rates. And when you combine these two dynamics together, community-based ART will also prevent the ratio of female to male HIV prevalence from increasing from 2 in 2020 to 3 by 2060. So in total, we estimate that community-based ART delivery will avert over 950,000 HIV cases and over 870,000 deaths by 2060. And so taking all this information, and I see there's some comments in the chat, maybe we'll just wrap up and then come back to those. So after this, our next step is to combine these population health impact measures with cost data and health economics metrics to estimate cost effectiveness of community-based ART. And so I'm going to provide a preview now, and I think that this information will be discussed further at a later workshop. So first, we can directly use those HIV infections and deaths averted from that last slide in each scenario to calculate the cost per HIV infection or HIV death averted with community-based ART. Second, we can use model outcomes to calculate QALYs and DALYs, which Jim talked about, which form the basis for some other cost-effective metrics such as ICERs. So remember that DALYs, or disability adjusted life years, measure disease burden as years with compromised health plus years of life lost. And so we can use, so if we take that living with HIV contributes to years of disability with lower CD4 linked to higher disability weight, we can take the number of persons with HIV by CD4 over time from the model and use that to calculate years living with disability, and also take the number of HIV-associated deaths from the model and use that to calculate years of life lost. And in that way, use these model-generated metrics to calculate DALYs over time, or in some of those over time. And so by comparison, QALYs, or quality-adjusted life years, measure health as health status over time plus longevity. And so for this calculation, we output the number of persons who are HIV negative or those with perfect health. And among persons living with HIV, we link higher CD4 to a higher utility weight, and again, use the number of persons with HIV by CD4 over time to calculate years with imperfect health, sum these over time to generate QALYs with each intervention. So in conclusion, increasing viral suppression through community-based ART quickly and significantly reduces mortality among men living with HIV and decreases the high HIV incidence rate among women. By eliminating the gender disparity in viral suppression, we can thus improve health for the entire community, particularly in settings with a generalized HIV epidemic and high HIV prevalence. However, even with community-based ART, we predict that HIV prevalence will remain above 12% in 2060. Additional interventions will be needed to reach that UNAIDS 95-95-95 goal. So in this workshop, we've exemplified how transmission models are critical for generating evidence on potential population health impacts. And we're currently conducting a cost effectiveness analysis as a follow-up to these results I just showed to understand how the health impact of community-based ART compares to the cost of the intervention. We're also looking at a budget impact analysis to understand affordability. In the next workshop on April 18th, we'll go into more details about how to use these model outcomes and conduct a cost-effective analysis, going into more detail on those economics metrics. And then I just want to quickly acknowledge the co-authors on this work and the funding resources that made the investigation possible. And thank you. I'll stop sharing and maybe we can come back into a discussion here.
Great. Super job. I've saved us 20 minutes for discussion. I'm so happy that we got through all that. Excellent job, Cara. So I think the main point is that the study measured viral suppression. It did not measure changes in HIV incidence, but we were able to use the math models that captured viral suppression and behavior to then go on and estimate changes in HIV incidence. And because of and then using the costs for both achieving the service and cost averted, we'll be able to estimate cost effectiveness. Okay, we're very happy to take questions and have some discussion. When you introduce yourself, please tell us a bit about who you are and what your interests are. And if you have questions outside of what we presented, please do take advantage of this time, since we don't have the socializing time around coffee and other things, but we do want to hear from you.
Hi, this is Tessa again. My limited experience with complex models like this is that you typically have to have large N sample sizes or N values in each of these categories. And in a lot of the research I've done, we're limited by power to do this. So are there models that you've used that can work around this and can sort of adapt to smaller sample sizes or?
So Tessa, you ask a great question. What should you do when there's uncertainty in the data? When actually there's still a lot of unknowns, but this is the best data you have. And I think the best way forward then is to capture the uncertainty in the model values. So Cara showed the uncertainty in the gray shaded areas. And so you'll, by definition, your model will also have a fair amount of uncertainty, and the credibility interval should reflect the uncertainty in the observed data, but hopefully will also be a motivating factor to collect additional information. Models can't tell us anything that we don't know empirically, but they can give us insights into mechanisms and potential ways forward. But empiric evidence is still the gold standard.
Hey there. Thank you, both of you, for, I hope you can hear me, for such a great presentation. I asked a question and I thought maybe we could talk a bit more about that just to kind of get inside of the model. I was sort of curious, this particular model, we observe that you see this great reduction early on, and then of course your findings are additional interventions will be needed. Ruanne answered my question why it leveled off, saying you have a maximum proportion of persons on ART with suppressed viral load as observed. So I'm really curious, kind of getting back to that sensitivity analysis. Do you have to always specify a maximum proportion of persons on ART? Ruanne, would you lower that, assuming you might have drop off? Could you increase it, assuming there are other investments being made in South Africa that might in fact increase? I'm just curious how you deal more around that assumption of maximum proportion and ways that you may vary it, given that this was based on observed. Thanks. Super interesting. Thank you.
Great question. I'm going to let Cara go first and answer.
Yes, I think that's a really important question about both some pieces that are potentially policy related as well as some pieces that are potentially assumption related in the model. And so touch first on the policy piece. It's this question of, might there be additional ways that we can scale up ART to reach a higher value? And I think that we kept it level in order to stay tied to that, do our viral suppression results. But I think that could be an important question of if you have a policy where you scale up further, that might be a way that you could include that as maybe like a sensitivity analysis. Another piece I think ties into this that we use in this analysis was what happens if there's other interventions going on in the background, such as scale up of voluntary male medical circumcision, which is another way that like maybe there's other intervention that's happening that could affect your results. And so that's another place that you could include a sensitivity analysis where you look at, okay, if this is happening in the background, how does that affect your model results? Ruanne, do you have anything to add?
Yes, so absolutely, we will go on to use the model to estimate the impact of new interventions. There are, we just had CROI, there are a whole lot of interventions showing even higher viral suppression than we demonstrated. And so I think we would definitely go on to include those in the model. And that's part of kind of the blue sky thinking that modeling can also allow you to do, to really test out new ideas. If everyone is virally suppressed and we're able to get everyone on treatment, what would be the effect on incidence, like that very first model that I showed? That was totally theoretical and a great way of thinking of complex problems.
Thanks. While we may wait for more questions, please, folks, raise your hands. I do have another one for both of you. This is so interesting. Thank you. So COVID, of course, is on front and foremost on everyone's mind. And I just wondered if the two of you could share, how is your team thinking about the impact of COVID on access to prevention and treatment? And if you've started to think about that, or any thoughts about how you might include that in future models. And again, if somebody else has a question, please raise your hand. But in the meantime, I think that might be an interesting one for our participants.
So great question. Thanks so much, Carol. At ICAP, Dr. Tiffany Harris presented the resilience of 31 healthcare facilities that have provided ART throughout COVID. And they did see some declines in Q2 of last year of HIV testing and of the numbers of people initiating ART. But they did show that in Q3 that those declines had disappeared and they were back up to increasing levels. And also the facilities maintained ART delivery and viral suppression throughout. So I think that shows the resilience of programs, especially programs that had incorporated as strategies for differentiated care delivery. And in fact, before COVID was even 3 months old, they were already modeling analyses showing the detrimental effect that it would have on viral suppression, which maybe played the part in spurring people on to ensure that ART was delivered. We've never experienced as much cooperation with the Department of Health, who are our strong and everyday partners in the work we do in KZN, as we did during COVID. We were conducting a study at that time and we had all kinds of special licenses and we were able to really access treatment, and the Department of Health worked with us so closely to ensure that they were able to deliver ART. So there might be that kind of silver lining. Of course, it's not a rosy picture everywhere, but they in many places, as we saw from the data, there were ART supply was maintained, and so I think we'll learn from this. Yeah.
Okay.
And yeah,
Thank you.
Yeah, hopefully modeling spurred people on to get that done. But there were all these dramatic models of how terrible it would be, and of course, I'm sure that there will be some effects. Would anyone like to share why they came to the presentation today and what project they're working on? And do they have questions about their own work and their own? Usually if we were meeting in person, we would break up into small groups and you would draw your own decision tree and reflect on what your questions are. So can someone tell us about their project, and are there potential health economic questions? I know some of you, so I might call on you unless you volunteer first, which would be preferable.
Hi, this is Yang Feng. Currently, I'm an acting assistant professor in the Department of Global Health, and I work closely with Ruanne, and I also had a discussion with Cara in organizing this seminar. Both me, myself, as well as my colleagues really appreciate the opportunity to learn more about the concepts, methods, as well as the latest change in this field. And for me, myself, I'm doing several CA analysis, including one in South Africa. And for my own application, I'm also thinking more about disease modeling, and like really excited that we are going to have like future sessions to further our discussion. Thanks.
I believe that there must be more health economic modeling questions out there, but maybe now is not the time. So feel free to approach us by email, or maybe Carolyn and I will stay in the room for a little bit for the last 10 minutes. But if you need to drop off, or we just want 10 minutes back of your day, we're happy to give that to you. But if you have a specific project and you have questions and you're interested in health economic approaches and math modeling, please do feel free to stay in and ask those questions. Thanks so much for attending today. Please complete the survey as we work hard to do this well remotely.
I can ask a quick question. So my name is Natalie Cobb. I'm actually a fellow in pulmonary and critical care at UW, and I don't have any experience with cost-effective analysis, and so I was attending today primarily kind of as an introduction. I do have interest in it, and I think I have done a fair amount of work in global health, and I think one of the questions that has kind of been on my mind in the setting of COVID is cost effectiveness of kind of basic critical care is not something that's really been evaluated in lower resource settings. And so that's one of the reasons I think I'm interested in learning a bit more about this. I think one of the challenges that I kind of perceive with this is that in critical care in general, or kind of basic services for critical care, there's not necessarily a lot of empiric data to show efficacy for certain approaches or certain management styles. And so I think, I'm kind of curious about, there's been some discussion about using empiric data or observational trials and kind of what's been done in that versus using more modeling approaches and kind of justifying your assumptions. And so I guess my question there would be, you know, when data is limited to suggest the benefit of a certain therapy, how do you go about, you know, kind of incorporating what's known into more mathematical modeling and incorporating those assumptions into what you're doing? And I see a question from Carol just saying how you define critical care. So I think it's a good question. So I think there's a lot that you could define as critical care, but I think in this setting, just to even keep something very simple. So I will say, for example, like, you know, say we're talking about COVID, identifying people who have low oxygen levels and making sure that they're getting kind of oxygen therapy to support them through, you know, a respiratory kind of pneumonia. So I would call that a basic intervention for critical illness.
I'm happy to take this question, Ruanne, and then pass over to you or others to share their thoughts. I think there are two ways to think about this, Natalie. One is a traditional health technology assessment, or really you just focus on the very narrow issue, right? So one option is, and I'm going to give you two options, is to say, wow, we know in this setting, there's a public health need, and that need is we need a pulse oximeters, or we need to better monitor this in the moment in something like COVID. And then you really, you know, unfortunately, it's really just defining your objective very specifically. The other option is, and when you raise, is health systems are very weak in the settings that we're working in. And so how do you take into consideration the potential impact and the investment requirement to strengthen a health system? And so maybe in that way, there are some really interesting new work out there to help us explore these larger implications of investing in health systems to advance, to sort of optimize use of scarce resources. Does that sort of get at what you were thinking about? Over.
Yeah, I think that does. I think that's a helpful way to think about it.
Would anyone else like to add there? Great question. Happy to, Natalie, share with you two papers that you might find useful. So if others are interested, we'll make them available as post-workshop resources.
Well, thank you everyone for your time this morning. And we look forward to seeing you on April 18th.
Thank you, Ruanne, for chairing the session, and to all of our presenters, great work. Thanks. Lovely workshop. Thank you.
Thank you. Bye-bye.
And thank you for Danielle for organizing. I really appreciate that.
Thank you, Danielle.
Thanks,
Great.
everyone.
Thanks. Bye-bye.
Bye-bye.